Hello everybody, I am Dr. Ribbenick, and I'm back with another video. The very first video that launched this channel in 2018 was Introduction to Stroke, so needless to say, it's in need of an update. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. We do not have any relevant financial conflicts to disclose. As always, the case presented in this talk was modified for teaching purposes. I am assuming that you have a basic understanding of localization, cerebral vascular supply, and neuroimaging. If you need a refresher, please watch the cerebral vascular anatomy and imaging video on this channel. Finally, this is an oversimplification of an approach to a patient with stroke. Decisions regarding stroke care must be individualized to each patient and each institution. We will start with a case. Review the early steps in the management of acute ischemia and the main purpose of the stroke code to determine eligibility for acute stroke therapies. We will take a small detour to discuss the approach to transient ischemia and mild stroke. Next, we'll review the management within the first 24 hours after reperfusion, focusing on preventing secondary injury. At this point, we will talk about confirming the diagnosis of acute ischemic stroke with MRI and determining the stroke mechanism. Once we understand stroke mechanisms, we will review common stroke prevention therapies. And the ischemic stroke section will conclude with a brief summary. We will then switch gears to imagine how the early management steps would have been different had our patient presented with acute hemorrhagic stroke. And review 6 major hemorrhage mechanisms and hemorrhage prevention strategies. The hemorrhagic stroke section will be followed by a brief summary, including a review of blood pressure goals in patients with acute stroke. Use the chapter markers to jump directly to any of these sections. Throughout this talk, I will be asking questions, so feel free to pause and think those over. As always, if you get the answer wrong, nobody will know. Ready? Let's begin. We have a 74-year-old man, high functioning at baseline. He's independent, ambulates without assistance, drives, and manages his own finances. Our patient has the typical risk factors of hypertension, dyslipidemia, non-insulin dependent diabetes, and coronary artery disease. These risk factors are well managed with aspirin, lisinopril, metoprolol, atorvastatin, and metformin. He develops acute confusion, left facial droop, and left-sided weakness. Our patient went to bed without these deficits, and all these deficits were noted on awakening 7 hours later. His family called the emergency medical services, and the patient is brought to the emergency department. In this 74-year-old man with multiple vascular risk factors who developed acute significant focal neurological deficits within the past 7 hours, what are your thoughts? By the way, focal deficits are any deficits that can be traced to a particular area in the nervous system, unlike global deficits like lethargy and confusion that may be caused by multiple areas being affected simultaneously. What is the early pathological differential diagnosis? I can just hear you saying, stroke! Yes, but what else? The differential diagnosis of acute focal neurological deficits includes cerebrovascular pathologies, ischemic and hemorrhagic stroke, metabolic derangements, especially hypoglycemia, focal onset seizure or status epilepticus with Todd's paralysis. Todd's paralysis refers to a phenomenon where cortical neurons are exhausted by a seizure and temporarily cannot initiate action. It usually presents as a weakness, but depending on the seizure origin, it can be aphasia, visual disturbances, etc. Neoplasms. Yes, intracranial tumors can and do present acutely when surrounding edema reaches critical levels, tumor hemorrhages, or when tumor causes a seizure. Infectious and inflammatory pathologies of the central nervous system, encephalitis, brain abscess. In these cases, there's usually a history of fevers, constitutional symptoms, or behavioral changes leading up to the acute presentation. And finally, complicated migraine may cause focal neurological deficits, but such severe deficits and new onset of migraines in a 74-year-old are unusual. So, considering this early differential diagnosis, and the fact that cerebrovascular pathologies top this list, what is the next best step in the management once the patient arrives to the emergency department? Right! Call a stroke code. You realize that this is a neurological emergency and you're likely going to need some help. Now, the purpose of the stroke code is to establish eligibility for stroke reperfusion therapies and to deliver those therapies as quickly as possible. That's it. We're not focusing on the diagnosis. A stroke code is too hectic and too time constrained for a proper history and neurological exam. A stroke code is not the same thing as a proper neurological evaluation. Once the stroke code is called, remember to focus on the 7 Esses. Significant history, like stroke risk factors, and especially the use of anticoagulants and the time of last dose. Knowing this information will help you assess the risks of fibrinolytic therapy. To estimate viability of at-risk brain tissue, we need to know symptom onset time, or time last seen at baseline for unwitnessed events. We need to know symptoms and deficits prompting stroke code activation, especially if they're disabling. This helps with targeted neurological examination and to confirm the disability. Systolic blood pressure, which is important for stroke interventions. Blood pressure may need to be adjusted to a goal that's safe for fibrinolysis. Look at the heart rhythm. Is it sinus? Especially note if atrial fibrillation is present. This helps identify a common high-risk source of clots. Send stroke labs. These usually include fingerstick glucose, complete blood count, complete metabolic panel, and coagulation profile. And finally, perform the National Institutes of Health stroke scale. NIH stroke scale is a good screening examination to identify disabling deficits and to help localize the lesion, which of course helps interpret neuroimaging. Now let's say as you're examining the patient, the deficits miraculously resolve, and the patient's back to his baseline. What's going on? You're probably yelling at the screen, "Transient ischemic attack!" First, may I point out the rationality of yelling at a computer screen? I can't hear you. Second, I generally don't allow students to use the term transient ischemic attack, because it's become one of the most garbagey diagnoses in medicine. Interruption of blood flow to the brain, even transiently, is a very serious issue. And neurological deficits that result from that interruption of blood flow are brain pain. True transient ischemic attacks predict an impending stroke. But the vast majority of transient neurological deficits are not caused by cerebral blood flow problems. Toxic metabolic derangements like hypoglycemia or drug side effects, complicated migraines, peripheral vestibular dysfunction, in the case of dizziness as the presenting symptom, seizures, and decompensation of underlying, even undiagnosed dementia are by far the more common reasons for a person to have transient neurological disability. So, how do we identify those who are at a higher risk of stroke, those who suffered a true transient ischemic attack? Let's use the ABCD2 score. Patients with a true transient ischemic attack are usually older, over the age of 60, have hypertension, blood pressure surpassing 140 systolic over 90 diastolic, present with unilateral weakness or speech disturbance that lasts between 10 and 60 minutes, and they may also have a history of diabetes. Notice that not all transient neurological deficits are predictive of high stroke risk. Blurred vision, dizziness, confusion, unsteady gait, word finding difficulties, and even facial droop are not all that specific. Let's see how this works in the real world. Which one of these presentations is most likely due to transient ischemia? Is it a 25-year-old previously healthy woman with a history of headaches who presented with 40 minutes of left-sided sensory deficits with her typical headache? Is it a 57-year-old man with hypertension and diabetes who developed right arm weakness lasting 30 minutes? Is it an 88-year-old man with hypertension and baseline memory difficulties who has a 5-minute episode of disorientation? Or is it a 60-year-old woman with hypertension and dyslipidemia who has a 4-hour episode of vertigo? Right. It's the 57-year-old man with multiple vascular risk factors and a 30-minute episode of arm weakness, weakness being the most specific presenting sign. Okay, after that brief detour, let's get back to our own patient. First, the vitals. Blood pressure is elevated, there's tachycardia, but the rhythm is sinus. Respiratory rate and temperature are normal, and our patient is protecting their airway. His deficits persist, so let's apply the NIH stroke scale to examine him. NIH stroke scale is a nice rapid screening examination. It certainly does not replace the formal neurological examination, but it's easy to do and should help spot the major deficits. NIH stroke scale goes up to 42 points. The higher the score, the more severe the stroke. Our patient is a little lethargic, but opens his eyes and attends when his name is called. When awake, he's oriented to age and current month. He followed several commands and answered questions without issues. When shown his left arm, he did not recognize it as his own, so he has severe neglect. There's left homonymous hemianopia, visual field decrement, forced right gaze deviation, the eyes don't cross midline, and mild dysarthria. He is slurring his words, but you can still understand them. His left lower face is weak, and there is dense flaccid paralysis of the left side. He doesn't even withdraw to noxious stimuli. Ataxia is absent, and there's clear left-sided sensory loss. The total score is 19 points, so it's safe to say that the deficits are disabling and the lesion is severe. Okay, mild lethargy, severe left neglect, left field cut, right gaze deviation, dysarthria, left face, arm, and leg weakness, and left hemisensory loss. What is the most likely lesion location that accounts for all of these deficits? Right. Frontal, temporal, and parietal lobes are involved here. And the vascular territory? Correct. Right middle cerebral artery. Here's an illustration of vascular territories overlaid on the axial cuts of MRI. On the left side of the screen, the cut is through the high frontal lobe, and on the right side of the screen is the cut through basal ganglia. MCA territory is color-coded in pink and purple. Hemiparesis and facial paresis results from injury to the primary motor cortex or the descending motor fibers in the corona radiata and the posterior limb of the internal capsule. Horizontal gaze paresis is caused by the dysfunction of the frontal eye fields. Aphasia results from the injury to the dominant, usually the left hemisphere. Frontal lobe lesions affect expression, and temporal lobe lesions affect language comprehension. Hemisensory deficits and neglect result from parietal injury. Specifically, neglect arises from the dysfunctional non-dominant parietal lobe. And finally, injury to the temporal and parietal optic radiations results in the contralateral homonymous hemianopia, field cut. Now that we understand the localization and early differential diagnosis, it's time for some neuroimaging to confirm our hypothesis. And we'll start with the non-contrast head CT. Why? Well, it's an excellent study to exclude hemorrhage, with a sensitivity of over 90%. These are axial slices through the midbrain and basal ganglia. This patient is facing the top of the slide, and the patient's left is on your right. Let's get the obvious out of the way. There's no hemorrhage or mass effect, and the midline is where it should be. But what's abnormal here? You see it, right? There's a hyperdensity in the right sylvian fissure, so-called dense vessel sign, which is suggestive of a clot within the right MCA. Now let's look for early signs of stroke. With acute ischemic stroke, it typically takes 3 to 6 hours to develop a hypodensity corresponding to the edema of ischemic tissue. Are there any hypodensities? Yes, there's a small hypodensity in the anterior right temporal lobe, but the rest of the MCA territory looks undamaged. During a stroke code, a non-contrast head CT is usually accompanied by another study. CT angiogram of the head and neck with contrast. CTA is done to assess for vessel occlusion. Doing both CT and CTA together saves time in determining eligibility for stroke interventions. This is an axial maximal intensity projection showing the vessels of the circle of Willis. By the way, source CTA images are typically very thin, less than a millimeter, so we only see a portion of the vessel at a time. Here, maximal intensity projection allows us to overlap multiple individual slices of the CTA to see larger vessel segments. What is the abnormality? Correct. Right MCA is occluded, which correlates with the dense vessel sign on the non-contrast head CT. So let's summarize. We have a 74-year-old man with the typical risk factors of hypertension, dyslipidemia, non-insulin dependent diabetes, and heart disease. He develops neglect, right gaze deviation, left sensory motor deficits, and left field cut, a right MCA syndrome. NIH stroke scale score is 19, so the deficits are clearly severe. There was no evidence of hemorrhage or large mass lesion on the head CT, and the right MCA occlusion was confirmed with the CTA. At this point, we are roughly at 8 hours from the time patient was last seen at baseline. Now that we're fairly certain that this is an ischemic stroke in progress, what is the primary goal of treatment? Right, reperfusion. We need to remove the obstruction to blood flow, emphasis on the moo. Get the cow, the blood clot, off the road. Why? The penumbra core discussion is old news at this point, but in a nutshell, when a major vessel such as the middle cerebral artery is occluded, there is reduced blood flow in the territory supplied by the vessel. The subcortical structures supplied by the lenticular-striate branches from the MCA stem have no robust collaterals and become ischemic very quickly. This is the ischemic core. But there's a much larger territory, the penumbra, that is getting suboptimal blood flow from collateral vessels, like the anterior cerebral and posterior cerebral arteries. And because of these collaterals, the brain tissue can tolerate a reduction of blood flow for some amount of time. There's not much you can do about the ischemic core, but if the blood flow is restored quickly enough, penumbra will become normal tissue. And speaking of restoring blood flow, the two tools that we rely on are intravenous fibrinolysis, with drugs like alteplase or tenecteplase, and mechanical thrombectomy. Thrombectomy is a surgery where a catheter is inserted in the peripheral artery, ascended up the aorta and neck vasculature to access the intracranial lesion. Devices such as retrievable stents and suction catheters are then used to remove the clot. So how do these two treatments compare? What is the success rate of intravenous tenecteplase at dissolving cerebral clots? Well, overall, tenecteplase recanalizes about 1/3 of intracranial occlusions, and I'm being a bit optimistic here. That success rate really depends on the site of the occlusion. Tenecteplase seems to work better for smaller, more distal clots. So intravenous thrombolysis is not that great. Also, in mild non-disabling strokes, there is mounting evidence that intravenous thrombolysis is not really beneficial at all. In those patients, we load with dual antiplatelet therapy instead, but more on that later. What about the efficacy of thrombectomy? Well, the recanalization rate is close to 90%. Tell me, when was the last time you saw a medical treatment that was 90% effective? So that raises two questions. Why does intravenous fibrinolytic work so poorly? And why do we then still bother with intravenous fibrinolysis at all? Let's deal with the first question. You probably conceive of intracranial clots as having a core of red blood cells and fibrin, and that's true. But we now know that they also have an external shell surrounding the core. This shell contains neutrophil extracellular traps, platelets, and von Willebrand factor. Add to that more fibrinolysis inhibitors like plasminogen activator inhibitor 1 and protease nexin 1, and you have a clot resistant to being dissolved. So, this protective shell becomes a target for future thrombolytics. Now, what about today? Why do we bother with intravenous fibrinolysis? It has been estimated that as long as a major cerebral blood vessel remains occluded, a person loses about 2 million neurons per minute. And thrombectomy takes about 30 minutes to get going. You do the math. And also, multiple trials of bypassing intravenous fibrinolytic in favor of going directly to thrombectomy failed to show the superiority of that approach. Time is brain, my friends, and every treatment matters. Okay, so we've decided to give fibrinolytic. What criteria must be met before we can administer the drug? Time from stroke onset is a surrogate marker for brain tissue viability. So we start by recording the time of deficit onset, or at least the time last known at baseline when time of symptom onset is unknown. There also needs to be a reasonably high likelihood that symptoms are caused by a stroke, like in our case. Imagine a patient with known left temporal glioma who presents with language deficits. Can the aphasia be caused by a cerebrovascular issue? Possibly. But the known malignancy is the more likely cause, and you wouldn't treat that with a fibrinolytic. Next, blood pressure. Most patients with acute ischemic stroke present with hypertension. There's a catecholamine response in the setting of a stroke. But blood pressure above 185 over 110 millimeters of mercury increases the risk of bleeding with fibrinolysis. Blood pressure may need to be reined in a little to that goal before we can administer tenecteplase. Nowadays, we have very effective intravenous antihypertensive medications, so very high blood pressure should not be a barrier. During a stroke code, every patient gets a glucose check, because hypoglycemia may result in neurological deficits, even focal ones. Different parts of the brain use glucose at different rates, and therefore differently sensitive to hypoglycemia. The sweet spot for glucose before fibrinolysis is 60 to 400 milligrams per deciliter. In order to justify taking the small risk of hemorrhage, we need potential gains of significant neurological function. So NIH stroke scale serves to document disabling deficits, which is usually a score of 5 or above. By the way, it is possible to have disabling deficits and to administer fibrinolysis to a patient with NIH stroke scale score of 0. In case you didn't hear me, let me say that again. It is possible to treat a patient with an NIH stroke scale score of 0. How? Right. Gait ataxia and dysphagia are not scored on the NIH stroke scale, and neither is hand weakness. An isolated weakness in the dominant hand is certainly disabling, but the stroke scale score in that patient would be 0. Next, we absolutely need a non-contrast head CT, because there's no other reliable way of distinguishing ischemia from hemorrhage. CT may also show chronic lesions, large mass lesions, and early signs of ischemia. But in most patients with stroke symptoms occurring within the window for intravenous fibrinolysis, CT will be normal. I'll say that one more time. In most patients with stroke symptoms occurring within the window for intravenous fibrinolysis, CT will be normal. It takes at least 3 to 6 hours of ischemia for brain tissue to accumulate enough cerebral edema for it to show up as a hypodensity on the initial CT. Do we need to confirm a clot in a large vessel with CT angiogram before we can treat with tenecteplase? No, not at all. Smaller, more distal clots and disease in the subcortical vessels may not be visible on vascular imaging, but may benefit from thrombolysis. Next, labs are sent early during the stroke code. We're about to give fibrinolytic agent. Fibrinolytic agents may cause bleeding. So it would be nice to have a coagulation profile to know if the patient is at risk for bleeding, and maybe a type in screen to prepare for possible bleeding. But unless there's a history of bleeding diathesis, predisposition to bleeding, there's a low chance of abnormal labs. That's fortunate because labs take about 30 minutes to result, so we don't often wait for labs before thrombolysis. Time is brain. And speaking of contraindications to fibrinolysis, there are only two. Is the patient bleeding, or is the patient likely to bleed? The "is the patient likely to bleed" category includes recent brain or spine surgery, or a surgery at a non-compressible site, serious head trauma with traumatic brain injury, cerebral edema. I guess this could also fall under "is the patient bleeding" category. Full-dose therapeutic anticoagulation, like the use of warfarin with INR 1.7 and above, with therapeutic range being 2 to 3. The use of direct oral anticoagulants is also a relative contraindication, but their effect is a little harder to measure. So we only consider patients for fibrinolysis if it has been about 4 half-lives since the last dose of their direct oral anticoagulant drug, and the basic coagulation profile should be normal. Other causes of coagulopathy should be considered. For example, I get a little nervous administering fibrinolytic to patients with malignancy who are receiving chemotherapy, since those patients tend to have coagulation problems. So patients on anticoagulation and patients at risk for coagulopathy really weren't waiting for lab results. And finally, why do we note the time of deficit onset or the time last known at baseline? Oh, right, time is a surrogate marker for brain tissue viability. The standard window for intravenous fibrinolysis is 4.5 hours from known stroke onset. We have known for decades that at that 4.5 hour mark, the risk of bleeding begins to outweigh the benefit of salvaging brain. But how do we deal with cases where symptom onset is unknown? For example, our patient went to bed and woke up with deficit 7 hours later. Did the stroke start just as the patient fell asleep? Or did it start right before they woke up? Fun fact, it's usually right before waking up. Stroke incidence is linked with circadian rhythm. In case of unknown time of onset, time is no longer a useful variable. To confirm viability of brain tissue, we can replace time window with tissue window by performing multimodal imaging, CT perfusion, or brain MRI. I would really love to make everything easy and say that any person within 24 hours from last known well can potentially receive fibrinolytic using this strategy. But unfortunately, we only have supporting evidence for 9 hours from last known well. Okay, tenecteplase has been administered. Have we accomplished our primary goal of removing the obstruction? No. How can we tell? Well, 2 ways: the neurological examination and the CT angiogram. Our patient's deficits persist, and there's a proximal left middle cerebral artery clot that's not likely to respond to tenecteplase. We don't wait any time for miracles to happen, for TNK to work. We keep going. Now is a good time to review eligibility criteria for endovascular intervention. There are 4 major ones. First, reasonable baseline neurological function. Thrombectomy is not likely to change outcomes for the better in a patient who already has advanced dementia and is confined to bed. 2. The deficit must be disabling. If the only deficit is a mild facial droop, then what do we stand to gain? Side note: when a major vessel is occluded and the deficits are unexpectedly mild, it's possible that the occlusion is actually chronic and not acute. And this brings us to the third point. The occlusion must be acute, but also proximal enough to be within reach of our devices. So needless to say, there must be a clot. The procedure is called thrombectomy. You can't ectomize a clot that doesn't exist. And finally, patients that have brain left to save benefit the most from thrombectomy. We get baseline function from history. NIH stroke scale defines disabling deficits. CT angiogram confirms proximal occlusion in the cerebral vessel, but determining brain left to save is a little tricky, so let's discuss it. Imagine you have three very similar patients who suffer a right MCA occlusion. At the onset of occlusion, the brain tissue has not yet infarcted. But as the time passes, without treatment, the infarct grows and more penumbra becomes ischemic core. By 6 hours, the first patient's at-risk tissue becomes irreversibly damaged. In the second case, this happens at 12 hours. But the third patient may have a great deal of salvageable brain even at 24 hours. So, how do we identify that person with salvageable brain, the one that will benefit most from intervention? Well, there are two strategies: clinical to imaging mismatch and multimodal imaging. You examine your patient. Looks like a right MCA syndrome. You look at the CT scan, and there's no visible hypodense lesion to correlate with the deficits. The stroke is not yet complete. This is clinical to imaging mismatch. The deficits come from the tissue that is hypoperfused but still surviving, the penumbra. This strategy works well within the first 6 hours from stroke onset. What happens when a patient is beyond 6 hours, or worse yet, the time of stroke onset is unknown? You can still use the clinical to imaging mismatch if the head CT is favorable. There's no large hypodensity. But to be sure, we should really use additional multimodal imaging to estimate ischemic core and penumbra. Since our patient presented 7 hours after last known well, and there was some evidence of early ischemia on CT, we performed a CT perfusion. Cerebral blood flow less than 30% of normal estimates the ischemic core. It's color-coded in pink. And the time to maximum estimates penumbra, which is color-coded in green. There's a more in-depth discussion of CT perfusion on our channel if you're interested, so it's not that important to dwell on it now. We're not trying to turn you into a neuroradiologist. But based on the colors, does our patient have brain tissue left to save? Absolutely! The mismatch ratio is 14.1. There's 14 times more penumbra than core. But what about examples like this? Traditionally, we would say that the ischemic core is large, and there's little to be gained by restoring blood flow to mostly damaged brain. But recently, multiple randomized controlled trials proved that dogma wrong. It seems that saving any viable brain tissue is worth it. Of course, patients with large completed core infarctions certainly do not do as well as patients with small cores. Let's summarize what we have so far. Our patient is a 74-year-old man with the typical risk factors of hypertension, dyslipidemia, non-insulin dependent diabetes, and heart disease. He develops neglect, right gaze deviation, left sensory motor deficits, and left field cut, right MCA syndrome. NIH stroke scale score is 19. The deficits are severe. There was no evidence of hemorrhage or large mass lesion on the head CT, and proximal right MCA occlusion was confirmed with CTA. CT perfusion shows that mismatch is present, and our patient is within the 24-hour window from last known well. Should he undergo mechanical thrombectomy? Absolutely, and as soon as humanly possible. So we are now in the angiography suite. This is the digital subtraction angiogram, the gold standard for vessel imaging. Patient is looking directly at you. The catheter is in the right internal carotid artery. As contrast is injected and X-ray pictures are taken in rapid succession, the contrast paints the vessel lumen. First the internal carotid artery, then anterior cerebral artery. There's that occlusion in the right middle cerebral artery. Notice something else? ACA typically supplies the medial frontal lobe. But here, ACA steps outside of its typical bounds and extends blood supply to the MCA branches. This is collateral flow in real time. This flow sustains at-risk brain tissue for some time. After the clot has been removed, there's complete restoration of normal blood flow, and the ACA goes back to supplying its own vascular territory. As we keep scanning, blood flows from the arteries across a capillary network into the venous sinuses and jugular veins. And this is the clot that the retrievable stent device fished out. Who knew that such a little clot could cause so much trouble? What's next? Let's re-examine the patient after thrombectomy. He's awake and alert. Neglect has improved, and he now recognizes his left arm as his own. Visual field cut is now partial. Gaze deviation has resolved. His strength has improved. Instead of complete paralysis, there is a drift in his left arm and some effort against gravity in the left leg. Sensory deficits have improved as well. An 8-stroke scale score went from 19 to 8. Nice. Have we accomplished our primary goal? We certainly did. Hey, where are you going? We're not done. Now we need to admit the patient and deal with goals 2 and 3 of stroke management. If the primary goal of acute ischemic stroke care is to remove the obstruction, what's the secondary goal? Right, to prevent secondary injury. And secondary brain injury could come from 3 major issues: hemorrhagic transformation of ischemic stroke, especially reperfusion injury when blood flow is restored to the ischemic core where autoregulation is non-functional. Ischemic lesion can grow and cerebral edema may worsen. We haven't yet diagnosed and addressed the cause of the stroke, so another stroke can occur. Finally, injury to the cortex may trigger acute symptomatic seizures, but this is generally rare. First, high blood pressure is the most salient risk factor for hemorrhagic transformation. We typically want permissive hypertension in the setting of acute ischemic stroke, up to 220 over 110 millimeters of mercury, or up to 180 over 105 if tenecteplase is being administered. This is done to reduce the risk of worsening ischemia. But after restoration of blood flow, permissive hypertension is no longer needed. It will only serve to worsen the risk of reperfusion injury. So now that MCA is open, let's target systolic blood pressure of 100 to 160 millimeters of mercury. Considering the risk for secondary injury we just discussed, patients should be admitted for close monitoring. This monitoring usually starts in the intensive care unit and continues in the stroke unit. What are we monitoring for? Neurological deterioration, which is defined as a 3-point increase in the NIH stroke scale score, but also factors that are likely to result in deterioration, like hypo or hypoglycemia and fever. Also, as I mentioned, cerebral edema may become a problem and cause signs and symptoms of elevated intracranial pressure. Cerebral edema usually peaks at day 3 to 5 after stroke onset. Our ultimate goal in stroke care is to prevent future recurrence of stroke. We start with antiplatelet therapy, like aspirin alone or in combination with clopidogrel in certain cases, and add statin. And we need to perform the stroke workup to ultimately tailor our prevention regimen to the mechanism of stroke. And speaking of stroke mechanisms, we'll review the mechanisms and diagnostics necessary to establish them in a moment. But first, how can we confirm acute ischemic stroke? I know, in our case the diagnosis is painfully obvious, but that's not always the situation. The gold standard of diagnosis is diffusion-weighted imaging sequence, along with its evil twin, the apparent diffusion coefficient. This sequence shows areas of energy failure, cytotoxic cerebral edema. Acute ischemia appears hyperintense or bright on DWI and hypointense or dark on ADC. The presence of this dichotomy is called restriction of diffusion. The diffusion of water is restricted in cells injured by ischemia. In acute ischemic stroke, restriction of diffusion appears as early as 20 minutes and persists approximately for 20 days, but the brightness fades over time. So, if a patient complained of focal neurological symptoms within the past several weeks, it is possible, using the DWI and ADC, to determine if those symptoms were due to an acute ischemic stroke. Does everyone suspected of acute ischemic stroke need a brain MRI? Not necessarily, but those nuances are best learned when taking care of actual patients on the wards. Our patient did get an MRI. Here are the axial DWI and ADC sequences with a cut through basal ganglia. Our patient is looking towards the top of the slide, with their left on your right. Describe the abnormality. Right, there's restriction of diffusion in the right head of caudate, lentiform nucleus, and likely the internal capsule. This corresponds to acute ischemia. This is not surprising, since the MCA clot disrupted flow to the lenticular striate branches, injuring the subcortical structures. What's striking is how little cortex was injured. The restoration of blood flow saved almost the entire right hemisphere. Now that we have accomplished reperfusion, prevented secondary injury, and diagnosed acute ischemic stroke, it's time to turn our attention towards diagnosing the actual mechanism. There are three major reasons for clotting: abnormal stasis of blood, which usually means that is something wrong with the pump, the heart; abnormalities of the pipes that carry blood from the pump to the brain, and here I mean vessel injury that promotes thrombosis; or something is wrong with the blood itself. There's increased clotting potential. Yes, this is the famed Virchow's triad from 1856. This concept still holds true today. But it has evolved and was refined a bit in the last 150 years. For example, we know that vessel disease occurs in small and large vessels. Large vessels are the ones that have proper names: middle cerebral artery, carotid artery, etc. We realize that cardioembolism occurs due to issues with heart structure, such as pathology of the atria, but also heart function, the regularity of beat. For example, atrial fibrillation is a common cause of cardioembolism. Hypercoagulability may be genetic or acquired, such as in patients with malignancy. These are the so-called TOAST criteria. They were originally established for the TOAST trial back in 1998 when we were interested in treating acute ischemic stroke with anticoagulation. Those were simpler times. Anyway, I simplified the criteria and removed some of the rarer causes of stroke. It's important to remember that assigning these categories depends on the clinical story and neuroimaging. There's no biomarker that can confirm cardioembolism or large vessel disease or small vessel disease as the exact cause of the stroke. So we can only determine the stroke mechanism as most likely or most probable. Also, stroke mechanisms are not mutually exclusive. A patient may have atrial fibrillation, large vessel disease, and small vessel disease. In fact, the same risk factors like hypertension, dyslipidemia, diabetes predispose people to multiple stroke mechanisms. So, stroke risk factors and stroke mechanisms are not the same thing. Also, we often have to address more than one mechanism at a time. Oh, and one more thing. In about a third of patients, most likely mechanism cannot be determined. This used to be called cryptogenic stroke, which has now evolved into embolic stroke of undetermined source, or ESES. As our diagnostic technologies improve, we're able to reclassify more and more ESES patients into traditional TOAST categories. And for that ESES patient where cause truly remains undetermined, the risk of future stroke is thankfully low. But I digress. Where was I? Oh, yes, I did say that identifying stroke mechanisms depends on the clinical history and neuroimaging. So let's delve into those. We start with small vessel disease. This is a coronal slice of the brain through the basal ganglia, with the patient facing you and the patient's left on your right. Pretty much every large vessel can give off small vessel branches, but when we talk about small vessel disease, we typically highlight lenticular striate arteries from the MCA, branches of cortical and leptomeningeal arterioles, and penetrating arterioles originating from the basilar and posterior cerebral arteries. An axial slice of the pons is pictured here. Clinically, the patients with small vessel disease stroke are older, over the age of 40, and have vascular risk factors like hypertension, dyslipidemia, and diabetes. By definition, the extent of brain injury is small, so symptoms are milder. Symptoms typically conform to the so-called lacunar syndromes. Lacunar is another name for small vessel. Contralateral pure sensory loss from thalamic ischemia. Contralateral pure motor loss from the injury to the internal capsule. A combination of contralateral sensory and motor deficits. And contralateral ataxic hemiparesis with ventral pontine injury. There are other lacunar syndromes, but these are the more classical presentations. And considering the anatomy involved, cortical deficits like aphasia, neglect, and field cut will be absent. What do these look like on neuroimaging? Once again, they are subcortical and small, usually less than 1.5 centimeters on an MRI. Here are two examples of diffusion-weighted imaging, axial slices through the pons and basal ganglia. These are showing acute infarctions in the left paramedian pons and the right thalomocapsular region, both of which were likely caused by small vessel disease. Here's another example, but this time FLAIR axial cut through the basal ganglia. There are chronic lacunar strokes, areas where injured brain has been replaced with CSF, but there are also more confluent, hyperintense areas in the subcortical white matter. Periventricular white matter receives the least amount of blood flow, so in patients with vascular risk factors, small strokes accumulate in this area. Rather than presenting with focal neurological deficits, this flavor of small vessel disease causes cognitive impairment and gait instability. What's the pathogenesis? Lipohyalinosis. In this cross-section of a gross specimen, the wall of a small arteriole is damaged and thickened with deposition of collagen. Cholesterol usually has little to do with small vessel disease. But cholesterol has a lot to do with this next stroke mechanism, large vessel disease. By large vessel, I mean vessels like cervical internal carotid, intracranial middle cerebral artery, basilar artery, vertebral artery. You get the idea. And here is an illustration of the atherosclerotic plaque at the bifurcation of the common carotid artery. Notice that plaques tend to form at bifurcations of vessels, where blood flow is most turbulent. Once such a plaque becomes unstable and ruptures, it becomes highly thrombogenic, and pieces of plaque and clot embolize to the brain. Here's a cross-section through such a plaque. Notice the intraplaque hemorrhage. Just as with small vessel disease, patients tend to be older and tend to have vascular risk factors. You might say that patients predisposed to small vessel disease will likely be predisposed to large vessel disease too. Sometimes plaques warn you about their instability. Do you remember transient ischemic attacks? Of all the stroke mechanisms, it is large vessel disease that's most likely to present with transient ischemia, shortly followed by a full-blown stroke. What are the neuroimaging features? You should find significant stenosis in a vessel that supplies the infarcted territory. For example, if a patient has anterior circulation stroke, you might find carotid artery stenosis. Carotid artery supplies the anterior circulation. Look at this example. MR angiogram of the neck with contrast on the left, and CT angiogram of the neck with contrast on the right. Both images come from the same patient, and you're viewing the neck from the side, with the patient facing the left side of the slide. Common carotid artery, carotid bifurcation, internal carotid artery. What's the issue? Do you see it? Yep. After the bifurcation, internal carotid artery lumen narrows significantly. And you can use your imagination to picture a plaque that's narrowing it. And on the CT angiogram, you can notice different components of the plaque. Here's the axial slice of the internal carotid artery magnified. The lumen is filled with contrast, and the outer rim is calcified, which suggests a chronic, stable plaque. There's a large hypodense area that corresponds to a soft plaque, an unstable plaque, an area that's highly thrombogenic and can send off emboli to the brain. And this artery-to-artery embolism usually results in smaller strokes, like the one pictured here in the left precentral gyrus. The stroke looks wedge-shaped and cortical because a piece of the carotid plaque or associated thrombus probably occluded a small branch of the middle cerebral artery supplying that brain. Another mechanism by which large vessel disease causes stroke is flow failure. Imagine that the carotid artery plaque grows to a point that it causes a significant stenosis, say 90%. Take high-grade carotid stenosis, add a dash of hypotension, and you have flow failure. Intracranial collaterals can supply the cortex for a time, but the vulnerable watershed zone between the supply of the anterior, posterior, and middle cerebral arteries often takes a hit. These watershed infarctions often have a string of pearls appearance. Okay, so that's that for large vessel disease. Atherosclerotic lesions in patients with vascular risk factors that may present with transient ischemia that proceeds to full infarction. And strokes either look like smaller artery-to-artery emboli or affect watershed zone with flow failure. Let's talk about cardioembolism next. There's generally a striking difference between how cardioembolism and large vessel disease presents clinically. Emboli from a cardiac source tend to be large and multiple. Imagine that the stem of a normal MCA suddenly gets occluded by an embolus. The entire MCA territory is hypoperfused and patient will have severe deficits. Occasionally, as the embolus fractures and moves distally, occluding smaller MCA branches, the deficits that were maximal at onset get better. Think about it. It makes sense that the symptoms would be milder when smaller branches of MCA are occluded, as opposed to the MCA stem or the parent internal carotid artery. Now compare that to large vessel disease. How long does it take to form an atherosclerotic plaque in the MCA that's significant enough to affect blood flow? Months? Years? It's a slow process. In that time frame, the brain slowly adjusts, increasingly relying on collateral flow. If MCA stenosis progresses to the point of occlusion, the stroke will likely be relatively small, since the brain has had a chance to adapt. This discussion is convenient for learning, but not entirely reliable. For example, even a mild MCA plaque can rupture, form a massive thrombus, and occlude the MCA stem suddenly. In this case, the deficits would also be severe and maximal. So we need to rely on neuroimaging features to help with the diagnosis of cardioembolism. What would you expect to see on MRI? Large infarctions due to occlusions of major intracranial vessels. Here are axial DWI images from 2 patients with cardioembolism. Right MCA territory stroke and left PCA territory stroke. The other stroke pattern that hints at cardioembolism is multiple small infarctions in various arterial territories, especially involving the cortex. Here are 2 images from the same patient to illustrate the so-called embolic shower. Okay, so we now know how to recognize potential cardioembolism: severe deficits, large zone of infarction, or smaller infarcts in multiple vascular territories. Also, vascular imaging can help us confirm the absence of serious stenosis in the vessels that supply the infarcted territory. What are high-risk cardiac sources of emboli? Atrial fibrillation is by far most common in an older adult population. During a bout of atrial fibrillation, the left atrium and the left ventricle beat out of synchrony with each other. Blood stagnates, and a clot forms, usually within the left atrial appendage. When the heart returns to sinus rhythm, the clot is pumped to the brain and systemic circulation. Left ventricular thrombi form in patients with heart failure. Endocarditis, septic due to bacterial infection, or merantic with sterile clots can cause cerebral embolism. Aortic arch atheroma can also cause embolism. Technically, aorta is a large vessel and not a heart structure. Well, duh. But emboli from aortic arch plaques can travel to multiple cerebral vessels, causing embolic-looking strokes. So we'll leave it in the cardioembolic category. Pathology of the left atrium, associated with multiple vascular risk factors, may be thrombogenic even without atrial fibrillation. Heart failure with decreased ejection fraction may also cause emboli, even without a cardiac thrombus. Not everything that embolizes from the heart is a clot. Let's not forget pieces of benign tumor, atrial myxoma in the young, and fibroelastoma in the older adults. Finally, the cardioembolic source with the lowest risk, patent foramen ovale. PFO is a small flap-like opening between the left and right atria of the heart, a remnant of normal fetal circulation. Clots may form in the venous system, say in the leg or pelvic veins, and travel from the right to the left side of the heart, across a PFO. This so-called paradoxical embolism is very rare. So all of these can cause, cue cheesy animation, embolic strokes. The last major ischemic stroke mechanism is hypercoagulability. When do we suspect a clotting disorder? Stroke at a younger age, especially with a personal or family history of previous thromboembolism. Miscarriages late in the second or third trimester. The use of prothrombotic drugs, like oral contraceptives or hormone replacement therapy. Symptoms compatible with a connective tissue disorder, like systemic lupus erythematosus. And symptoms and signs of occult malignancy. Loss of appetite, weight loss, fatigue, cough, change in bowel habits, hematuria. By the way, in patients with malignancy, strokes are not unexpected. But for us stroke neurologists, stroke may be the first sign that leads to the diagnosis of malignancy. What is the pathology here? Well, in an adult, we'll usually look for acquired thrombophilia, which includes antibodies that promote clotting on the platelet surface, and malignancy. Take a look at this DWI study done in a patient with known pancreatic cancer who presented with stroke symptoms. The abnormalities are kind of obvious. It looks suspiciously like that embolic shower we just discussed. So neuroimaging is unfortunately not that distinctive here. You would have to rule out a cardioembolic source before attributing these strokes to hypercoagulability of malignancy. What's really helpful is finding multiple thrombosis in other organs, or thrombosis in circulations that don't usually thrombose. Wait a minute, this is not the brain. What's a CT of abdomen and pelvis with contrast doing in a stroke talk? Well, how else would we know that this patient with malignancy suffered splenic and renal infarctions? Once I see ischemia in multiple organs, I get worried about hypercoagulability of malignancy. That was a lot of information, but hopefully at least now you understand the major stroke mechanisms. Not all stroke mechanisms are created equal. Which mechanism is most dangerous? Which is likely to result in frequent stroke recurrence without proper treatment? Let's illustrate the concept of ischemic stroke risk with dogs. Small vessel disease is like a small French bulldog. Risk of stroke recurrence is several percent per year. Large vessel disease is like a medium-sized border collie. Stroke risk is around 10%. Cardioembolism is a German shepherd. Stroke risk is about 15 to 20%, depending on the cardioembolic source. The Great Dane represents hypercoagulability. Stroke risk may be as high as 30% in patients with malignancy. Embolic stroke of undetermined source is a bit unpredictable, kind of like this kitten. Most patients with embolic stroke of undetermined source have a very low risk. but a small subgroup may have a high stroke risk, a tenfold increase. So it's very important to do a thorough stroke workup to find and address all clot-causing pathologies. And speaking of the workup, it takes a bit of detective work and clinical reasoning to arrive at the most likely stroke mechanism. We need to check the pump, the vessels, and the blood. Heart structure is assessed with echocardiography, and heart function is assessed with cardiac telemetry. Every patient with acute ischemic stroke generally gets a transthoracic echocardiogram, an EKG, and several days of hospital telemetry. But if you truly suspect a cardioembolic source, you would need to go further to transesophageal echocardiogram and weeks of outpatient cardiac monitoring. Transesophageal echocardiography increases the sensitivity for detecting a cardioembolic source by approximately threefold. Extended cardiac monitoring increases the chance of picking up atrial fibrillation by about 4 times. Every patient with acute ischemic stroke needs vessel imaging, either CT angiogram of the head and neck with contrast, or MR angiogram of the head without and neck with gadolinium. For our purposes, the two studies have more or less equivalent resolution, but MRA takes longer to perform. So, in the setting of a neurological emergency, we typically choose CTA. Of course, we also assess modifiable risk factors that predispose patients to small and large vessel disease and cardioembolism. We are talking about dyslipidemia, diabetes, hypertension, smoking, sedentary lifestyle, alcohol overuse, obesity. This includes checking hemoglobin A1C level and the lipid profile. When a clotting disorder is suspected, we look for occult malignancy, typically using a contrast-enhanced surveillance CT of the chest, abdomen, and pelvis in the inpatient setting, and colonoscopy, mammogram, and PET scanning in the outpatient setting. We also perform laboratory testing to check for major procoagulant antibodies, including beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant. Let's get back to our case for a moment. As a reminder, this is a 74-year-old man with multiple vascular risk factors, including hypertension, dyslipidemia, diabetes, and coronary artery disease, who developed acute right MCA occlusion and was successfully reperfused with tenecteplase and mechanical thrombectomy. What stroke workup would you like to perform? I'll give you a moment. His cardiac workup included a transthoracic and transesophageal echocardiograms and several days of in-hospital telemetry. Both were unremarkable. After reperfusion, there was no evidence of clinically significant stenosis, more than 50%, in the right MCA or its parent vessels, the right internal carotid and the right common carotid. Diabetes was well controlled, with a hemoglobin A1C under 7. LDL was elevated. There were no signs or symptoms of malignancy or coagulopathy, but let's just say that surveillance scan and coagulopathy panel were performed for good measure. Both were negative. What is the stroke mechanism? Well, let's see. A large vessel was involved, so this can't be small vessel disease. Large vessel atherosclerotic disease was essentially ruled out with the gold standard study, the conventional angiography that was performed post-thrombectomy. Severe deficit in onset, major vessel occlusion, certainly sounds like cardioembolism. Unfortunately, we have not confirmed a cardioembolic source. There was no coagulopathy. What's left? That's right. Embolic stroke of undetermined source. Well, that's frustrating. All that testing and still no final diagnosis? The patient is being discharged. Are there any other tests you would recommend? While you're considering that, let's review stroke prevention therapies, the real reason why we try so hard to pinpoint the most likely stroke mechanism. We start with small vessel disease. And the name of the game here is aggressive risk factor modification. Quick question. What's the most important risk factor for future stroke? That's right, hypertension. Now, what's the second most important risk factor? Nope, still hypertension. Okay, how about the third most important risk factor? You guessed it, hypertension again. Hypertension increases the risk of ischemic stroke by 4 times and hemorrhagic stroke by 9 times. So, first step, adjust the antihypertensive regimen to achieve the long-term blood pressure goal of less than 130/80 millimeters of mercury. Statins also have strong efficacy data, presumably because of their anti-inflammatory and plaque stabilizing effects. Oh, and yes, they also lower cholesterol. In the first 90 days after an acute ischemic stroke from small or large vessel disease, the risk of another stroke is elevated. What we've learned more recently is that a short course of dual antiplatelet therapy, like combining aspirin with clopidogrel or aspirin with ticagrelor, can help reduce that increased stroke risk by about 20%, with a tolerably small increase in major hemorrhagic risk. After 30 to 90 days, we transition to single antiplatelet therapy, typically aspirin. This is because over the long term, dual antiplatelet therapy for stroke prevention tends to do more harm than good. As the stroke risk falls, the bleeding risk from dual antiplatelet therapy begins to overtake the benefit in stroke reduction. Lastly, lifestyle modifications, like improving glycemic control, following a healthy diet, quitting smoking and substance use, and increasing physical activity. They also reduce the stroke risk. But the medications we've discussed are far more effective than lifestyle modifications alone. So, if a patient insists on relying solely on diet and healthy lifestyle instead of taking medications, I tell them they're welcome to follow a diet, as long as it's a diet rich in antihypertensives, statins, and antiplatelet agents. Next, let's talk about large vessel disease. The risk factor modification strategy is the same as for small vessel disease. In fact, short-term dual antiplatelet therapy might be even more effective in patients with symptomatic large vessel atherosclerosis. Beyond risk factor modification, for large artery plaques, particularly occlusive disease in the carotid artery in the neck, and some intracranial vessels, we also have surgical options. One option is an endarterectomy, where the inner lining of the artery, along with the plaque, is surgically removed. Another option is angioplasty with stenting. There, a small mesh tube is inserted into the narrowed artery to keep it open and press the plaque against the vessel wall to prevent cerebral embolization. To make a long story short, both procedures are equally successful and durable. But stenting carries a higher risk of stroke because the catheter can dislodge pieces of the plaque, sending them to the brain. Stenting can also be done in intracranial vessels, but it's much riskier, with a higher chance of stroke. In recent years, a modified version of stenting, called transcarotid artery revascularization, or TCAR, has been gaining popularity. Think of TCAR as a blend of endarterectomy and stenting. The key feature of TCAR is that carotid artery blood flow is temporarily reversed during stenting with the help of a small pump. This approach presumably reduces the risk of cerebral embolization during the procedure. No matter which procedure is chosen, the current guideline for intervention is symptomatic stenosis of 50% or more. In other words, a vessel has narrowed enough and the plaque has become unstable enough to cause an ischemic event. But the decision to offer a revascularization procedure isn't always quite that simple. Let's use a carotid lesion as an example. How do we manage a high-grade symptomatic carotid lesion? Yes, revascularization in addition to medical management. Now, it's true that the risk of stroke recurrence increases as the degree of stenosis in symptomatic lesions gets worse. But we've learned that even non-stenotic carotid plaques can be unstable and still carry a significant stroke risk. So, how should we approach a 30% carotid stenosis with unstable plaque that's sending emboli to the brain? And what about a high-grade carotid stenosis that's never caused any neurological symptoms? The decision to offer carotid interventions is best viewed as a spectrum. On the left, high-grade symptomatic lesions almost always need revascularization. On the right, asymptomatic stenoses are usually better managed with medical therapy. For most of those patients, medical therapy is safer than surgery. In fact, I'm going to put my foot down. You better have a damn good reason to operate on a vessel that has not caused an ischemic event, no matter how tight the stenosis is. In the middle, we enter the zone of risk stratification, where additional studies help us determine if a plaque is unstable and poses a high stroke risk. We don't yet know if surgery benefits unstable plaques regardless of stenosis severity. Stay tuned for more evidence. Now let's talk about cardioembolism. As with small vessel disease, everyone gets standard risk factor management. What was that again? Yes, statins, blood pressure control, and lifestyle modifications. But when there's a confirmed cardioembolic source, antiplatelet therapy just doesn't cut it anymore. We need anticoagulation. For the most common cardioembolic source, atrial fibrillation, we typically start direct oral anticoagulants like factor Xa inhibitor apixaban. If anticoagulation isn't an option, because of serious bleeding risks, for example, there are occluder devices. A device can be placed by endovascular means into the left atrial appendage, where clots often form with atrial fibrillation. By blocking this area from circulation, the risk of embolism is reduced. For certain patients with a patent form anomaly that caused a stroke, a different occluder device can be used to seal the hole and lower the risk of future emboli. All the treatments we just discussed cover the majority of scenarios. But what about the rarer cardioembolic sources, like endocarditis or cardiac tumors? I'll let you look that one up. You can't expect me to do all the work for you. Last but not least, hypercoagulability. In this case, anticoagulation is also essential. But direct oral anticoagulants may not be as effective as the old vitamin K antagonist warfarin or the injectable low molecular weight heparin enoxaparin. When malignancy is the cause of clotting, we also need to focus on treating the underlying cancer. Okay, stroke experts, let's get back to our case. This is a 74-year-old man with multiple vascular risk factors, hypertension, dyslipidemia, diabetes, heart disease, who developed acute right MC occlusion and was successfully reperfused with tenecteplase and mechanical thrombectomy. Given the absence of a cardioembolic source, clinically significant large vessel disease, or hypercoagulability, we label his stroke as an embolic stroke of undetermined source, Esses. So we initiated the standard risk factor modification regimen, and our antithrombotic therapy of choice was aspirin. He does not meet criteria for dual antiplatelet therapy or anticoagulation. He now returns for follow-up to the stroke clinic. Thankfully, he has recovered well from his stroke and has no further stroke-like episodes. He's taking his medications and denies any serious side effects. What are the next management steps? Or better yet, we label the stroke as embolic, so who in their heart of hearts feels that he might do better on anticoagulation? And if so, how do we confirm an indication for anticoagulation? To answer this question, we need to carefully reassess for any missed cardioembolic sources. We should search for atrial fibrillation. Do prolonged cardiac monitoring with mobile cardiac outpatient telemetry or implantable loop recorder. If we confirm a cardioembolic source, we will be able to switch to anticoagulation. And on day 15 of cardiac monitoring, we finally detected atrial fibrillation. Aspirin was promptly switched to anticoagulation with apixaban, and they all lived happily ever after. The end. Just kidding. If you dozed off midway through this talk and are just waking up, welcome back. Let's summarize the management and prevention of acute ischemic stroke. A patient presents within 24 hours of their last known well time with acute focal neurological deficits. Activate a stroke code. Remember that the primary goal of acute stroke care is to remove the obstruction. During the stroke code, take care to focus on the 7 Esses: significant history, especially anticoagulant use, symptom onset, symptoms and disabling deficits, systolic blood pressure, non-sinus rhythm, especially atrial fibrillation, stroke labs, and the NIH stroke scale score. Perform brain and vascular imaging. Then consider reperfusion therapies such as intravenous tenecteplase and mechanical thrombectomy. If the deficits rapidly resolve, it's still important to look for significant large vessel stenosis. That's the most common cause of transient ischemia. Estimate a patient's stroke risk by calculating the ABCD2 score. For patients with high ABCD2 score and non-disabling deficits, consider loading with dual antiplatelet therapy instead of intravenous fibrinolysis. These patients typically don't seem to benefit from fibrinolysis. For everyone else, establish the timeline and assess the likelihood of stroke. Bring the blood pressure down to under 185 over 110 millimeters of mercury. Exclude hypoglycemia. Confirm disabling deficits. Exclude hemorrhage with the CT scan. Exclude any contraindications. And review the time windows. Remember that in patients with unknown time of stroke onset, tenecteplase may be administered within a 9-hour window, as long as additional multimodality imaging is favorable. Now let me just reinforce that point again. The 4.5-hour window is only applicable to patients with known or witnessed onset. When stroke onset is unknown or unwitnessed, we do collect times from last known well and times of symptom discovery, but those times are somewhat irrelevant. If we don't know when the stroke started, we can't just rely on the time window to treat. We absolutely need multimodal imaging to assess tissue. And when all the stars line up, proceed to intravenous fibrinolysis. Whether or not patient gets IV fibrinolysis, proceed to mechanical thrombectomy if the patient has reasonable baseline neurological function, there's a disabling deficit, there's an acute large vessel occlusion that's proximal enough for intervention, and ideally there is still enough viable brain tissue to benefit from thrombectomy. Remember that the primary goal of acute stroke treatment is to remove the obstruction, not just to give T&K. Once reperfusion has been achieved, the focus for the next 24 to 72 hours shifts to monitoring for and preventing secondary injury. Secondary injury can arise from hemorrhagic transformation, cerebral edema, extension of stroke, and acute symptomatic seizures. Permissive hypertension is no longer necessary, so systolic blood pressure should be reduced below 160 millimeters of mercury. Admit the patient for close monitoring, typically in the intensive care setting, before transferring to the stroke unit. Neurological deterioration is defined as at least a 3-point increase in the NIH stroke scale score. Injured neurons hate fever and hypo or hyperglycemia, so address these when present. Cerebral edema usually peaks between days 3 and 5 after stroke onset. It will be marked by signs and symptoms of elevated intracranial pressure and worsening mass effect and midline shift on follow-up imaging. Finally, to prevent stroke recurrence, start antiplatelet therapy and statins, and then perform the stroke workup to tailor your treatment to the specific stroke mechanism. And speaking of the workup, check heart structure with a transthoracic echocardiogram and proceed to transesophageal echocardiogram as appropriate. And check heart function with EKG and telemetry. By this point, vessel status has typically been assessed by the CT angiogram during the stroke code. But if that hasn't been done, perform the CT angiogram or MR angiogram now. Check laboratory markers for vascular risk factors, including hemoglobin A1C and lipid profile. Assess for risk factors for coagulopathy and consider sending a coagulopathy panel and performing a malignancy screen, where appropriate. You're looking to establish a stroke mechanism. Small vessel disease, large vessel disease, cardioembolism, hypercoagulability, one of those. Small vessel disease occurs in patients with vascular risk factors, the strokes are less than 2 centimeters in diameter and subcortical, and we typically need to exclude other, more dangerous stroke mechanisms. Small vessel disease is addressed with aggressive risk factor modification, antihypertensives, a short 30 to 90 day course of dual antiplatelet therapy, followed by aspirin, statin therapy, and lifestyle changes. Large vessel disease also presents in patients with vascular risk factors. So, MRI and vascular imaging are extremely helpful to confirm symptomatic stenosis of more than 50% in a large vessel. Typically, some workup is conducted to exclude cardioembolism and coagulopathy before proceeding to endarterectomy or stenting. Of course, all cases of large vessel disease also require medical management of risk factors. Large vessel occlusions or strokes in various arterial distributions raise concerns for cardioembolism. These patients need a careful evaluation for structural cardiac abnormalities and atrial fibrillation. Once confirmed, the cardioembolic source is treated with anticoagulation or occluder devices. Finally, hypercoagulability. Assess for risk factors for coagulopathy and signs of occult malignancy. Strokes in this category generally appear embolic, but no cardioembolic source or symptomatic large vessel stenosis will be identified. Hypercoagulability is managed with anticoagulation and addressing the underlying cause. Embolic stroke of undetermined source should prompt a careful reassessment for any missed embolic sources. This should definitely include prolonged cardiac monitoring with mobile cardiac outpatient telemetry or implantable loop recorder to detect atrial fibrillation. Now, the 4 major stroke mechanisms certainly don't account for every possible cause of stroke. There are rare causes like dissection, cerebral vasoconstriction, cerebral venous thrombosis, carotid web, vasculitis, genetic arteriopathies, mitochondrial disorders, but that's a topic for another time, another residency, and another fellowship. I promised to cover all of stroke in one talk, and now is a good time to pause and take a break. Get ready, because we're about to travel through the multiverse. Follow me and ponder the question, what if? For the second week of your neurology clerkship, you are transported to another universe with a very similar hospital and emergency department. I know, multiverse float wasn't your first choice of a rotation site. I get it. But hey, as clerkship directors, we've got some serious capacity issues. Sometimes we have to venture into the multiverse just to find a place for our students to train. So don't complain. You're shocked to see the same patient present to the emergency department in the same way. You double-check your notes. A 74-year-old man, high-functioning at baseline, with typical risk factors and medication regimen, who developed acute confusion, left facial droop, and left-sided weakness. He awakened with these deficits 7 hours after his bedtime. Yep, the same patient. Even the exam seems to be the same, except it takes noxious stimulation to awaken him. He's a bit more disoriented and complains of headache. Head CT was performed. And surprise! It's a large hyperdense hematoma originating in the right putamen. There's mass effect and midline shift. Huh? How can a subcortical lesion present with cortical signs, just like an MCA syndrome? Keep in mind that if the cortex is damaged, or if the cortical structures get disconnected from the deeper relaying nuclei, like when a large hematoma interrupts descending pathways, the clinical picture will end up looking very similar. Now notice something very strange inside the hematoma. What is that dark canyon right there in the middle? This hypodense area represents acute bleeding. The blood hasn't clotted yet, so it remains liquid and therefore hypodense. Now, when we look at the same location on a contrast-enhanced CT angiogram of the head, we can see active extravasation of contrast into the hematoma, appearing as a bright spot. Both the black hole sign on CT and the spot sign on CTA indicate active bleeding and suggest that this hematoma is likely to expand. Now that we know we're dealing with a hemorrhage, what is the primary goal in managing an acute hemorrhagic stroke? We have to prevent expansion. The bigger the hematoma, the worse the outcome. Now is a good time to review the early management of acute hemorrhagic stroke. We just reviewed how to make the diagnosis of hemorrhage. That's reasonably straightforward. We got a head CT. Note that we already did vessel imaging as well, mainly to assess for a macrovascular cause, like an arteriovenous malformation. We'll dive into the causes of hemorrhages in a bit, but for now it's crucial to identify if there's a blood vessel issue, especially since our patient is actively bleeding. Remember the spot sign on the CTA? So you've confirmed the hemorrhage. Now what? Now we work to prevent secondary brain injury. Injury from what? Hematomas can expand, especially within the first 3 to 6 hours. Edema may also form around the hematoma. Together, those mechanisms can compress nearby brain tissue, causing increased intracranial pressure and even herniation. Cerebral edema also develops after an acute ischemic stroke, but at a much slower pace. It usually peaks at 3 to 5 days from stroke onset. For hemorrhages, though, this process is faster. You might have to deal with signs of increased intracranial pressure within the first 24 hours. Hemorrhagic brain injury can sometimes trigger acute symptomatic seizures, but just like with ischemic strokes, this is relatively rare. What was that primary goal of acute hemorrhagic stroke care? Yes, prevent expansion. There are two main strategies here: control the blood pressure and correct coagulopathy. Systolic blood pressure goals should be reduced rapidly to a target of 130 to 150 millimeters of mercury, and any coagulopathy should be promptly treated. In this universe, our patient wasn't taking an anticoagulant, so there's nothing to reverse. And notice, at no point did I say, call neurosurgery stat. Unless your patient is about to herniate, rushing into ultra-early neurosurgical intervention for intraparenchymal hemorrhage hasn't really been shown to help, and can actually do more harm. Thankfully, only about 1 in 8 patients with a hemorrhage actually show clinical signs of brain herniation at the time of initial evaluation. So let me say it again. In the first 3 to 6 hours after hemorrhage onset, your focus should be on controlling blood pressure and correcting coagulopathy, not calling neurosurgery. There'll be a time and place for surgical interventions. Next, admit the patient for close observation to the intensive care unit, preferably neurocritical care unit. These patients must be monitored closely for neurologic deterioration and the usual factors that are likely to worsen outcome: fever, glucose. Let's get back to our case. Our 74-year-old man with multiple vascular risk factors who developed acute right putamenal hemorrhage and had radiographic signs predictive of hematoma expansion. He's now in the ICU. His level of alertness is becoming more depressed. Vitals are okay. Blood pressure is within our goal. What is the next best step in the management? Yeah, let's repeat a non-contrast head CT. Here's the initial CT and the follow-up. Hematoma is definitely larger and the mass effect is more pronounced. Now might be a good time to address signs of elevated intracranial pressure. Early treatments like hyperventilation and hyperosmolar therapy are nice band-aids that will buy us some time. But ultimately, I'm talking about a definitive treatment: surgical hematoma evacuation. The indications for surgical hematoma evacuation are rapidly evolving. And here's what we know so far. Minimally invasive approaches are generally safer than traditional craniotomy, where the skull is opened to evacuate the hematoma. Two of the most well-supported techniques are MISTIE, minimally invasive surgery with thrombolysis in intracerebral hemorrhage evacuation, and ENRICH, endoport-mediated evacuation of intracerebral hemorrhage. MISTIE involves infusing small doses of TPA directly into the hematoma through a small, soft catheter, allowing the blood to gradually dissolve and drain passively over the course of several days. ENRICH uses a larger port, which allows direct visualization of the hematoma and its removal by suction. Patient is unlikely to benefit from hematoma evacuation beyond 72 hours, because the damage is already done by that point. But we don't yet know the ideal earliest time for removal. What we do know is that the longer the hematoma remains, the more toxic it is to the brain. But if we remove it too soon, we risk losing the tamponade effect, which can lead to rebleeding into the hematoma cavity. Hematoma needs to be large enough to justify surgery. Hematomas over 30 cubic centimeters tend to worsen outcomes, so that's typically where evacuation is considered. There needs to be neurological function left to salvage. Hematoma evacuation aims to prevent more damage, but if herniation has already happened, it's too late. And finally, despite all the uncertainties, one thing is clear: evacuation must be complete. If a significant amount of hematoma is left behind, outcomes won't improve. After completing the necessary workup and preparation, our patient's hematoma was removed using minimally invasive surgical approach. And speaking of the workup, the final step in managing a hemorrhagic stroke is preventing it from happening again. This means identifying the cause of hemorrhage so we can prescribe the appropriate prevention regimen. And this brings us to the last section of this talk: mechanisms of hemorrhagic stroke. There are 3 major reasons for clotting, but there are only 2 major reasons for bleeding: dysfunction of blood vessels or decreased clotting potential. The complexity comes when you consider that vessels of different sizes can be involved. When it comes to dysfunction of large vessels, we are concerned about an aneurysm at the branch points in the circle of Willis and an arteriovenous malformation. Vasculopathy is a broad term used to describe any pathology affecting blood vessels. In adults, the most common vasculopathy that causes bleeding is cerebral amyloid angiopathy. When the pathology involves inflammation, it's referred to as vasculitis. The same small vessels we discussed earlier, which when damaged by multiple vascular risk factors can lead to ischemic stroke, can also rupture and cause a hemorrhage. Finally, we shouldn't forget the smallest vessels that make up the blood-brain barrier, the pial arterioles. And what is the entity that stimulates the growth of fragile new blood vessels, invades existing ones, and disrupts the blood-brain barrier, causing bleeding? A neoplasm. At the beginning of all of this, I mentioned the term macrovascular without really defining it. It's a term you might come across in the literature. When bleeding starts from an abnormality in a large blood vessel, it's referred to as having a macrovascular cause. So, what tests do we need to diagnose these causes? First, all hemorrhage patients get a basic coagulation panel on arrival. Remember the primary goal of hemorrhage management? Control the blood pressure and correct coagulopathy? This panel includes prothrombin time and international normalized ratio, which are measures of extrinsic and common clotting pathways, and activated partial thromboplastin time, which measures the intrinsic pathway. Sometimes we need to order additional tests. For example, in patients taking factor Xa inhibitors, we'll check the anti-10A level. In patients on antiplatelet agents like clopidogrel or ticagrelor, we will check the level of P2Y12 platelet receptor inhibition. To assess for a macrovascular cause, we would order CTA or MRA of the head. A brain MRI with contrast is also helpful. The contrast enhances the areas where the blood-brain barrier is disrupted, helping us diagnose a hemorrhagic tumor. Also, MRI has specialized sequences that can detect chronic bleeding, and chronic microbleeds are a marker for vasculopathy. Let's talk about the mechanisms of hemorrhage in a bit more detail. Subarachnoid space is located between the pia and the arachnoid meninges. Blood vessels run through this space, bathed by CSF. When the vessel ruptures in the subarachnoid space, blood mixes with the CSF and causes chemical meningitis, which in turn causes the typical symptoms: thunderclap headache, neck stiffness, lethargy, nausea, vomiting. Here are 3 images from one patient. Remember that fluid is dark or hypodense on a non-contrast head CT. But on these images, there's extensive hyperdensity in the Sylvian fissure, intrapeduncular cisterns, and intrahemispheric fissure. These hyperdensities are within the subarachnoid space, so this is diffuse subarachnoid hemorrhage. Some of this hemorrhage is spilling over into the ventricles. So seeing blood in the subarachnoid space on a non-contrast head CT is diagnostic. Trauma is actually the most common cause of subarachnoid hemorrhage, but ruptured saccular aneurysms are the most common cause of non-traumatic subarachnoid hemorrhage. These aneurysms occur at the branch points in the circle of Willis, where the hemodynamic stresses of turbulent flow are the greatest. Makes perfect sense. And the vessels that are commonly involved are the anterior communicating artery, internal carotid artery, middle cerebral artery, and the basilar tip. Vascular malformations can also rupture into the subarachnoid space. Next, let's talk about arteriovenous malformations. AVMs are often found incidentally on imaging. When they do rupture and bleed, it usually happens in younger patients. Rarely, AVMs can cause irritation and edema in the cortex, leading to seizures or focal neurological deficits. What are the neuroimaging features? Here's a non-contrast head CT with axial cuts through the basal ganglia and frontoparietal region. Take a close look at the scan and see if you notice anything unusual. What stands out? In the middle image, you'll notice some wonkiness with the midline. It's shifted to the left. This tells us that there's something in the patient's right hemisphere that's exerting mass effect. Look at the right hemisphere closely. There are serpentine hyperdensities that resemble vessels. Based on their location, you can deduce that some of these are arteries and others are veins. Let's go to the MRI. T2 axial cuts through the frontoparietal regions. You can see the abnormalities much more clearly now. The multiple flow voids, which appear as serpentine hypointensities, correspond to a tangle of vessels. And here is that arteriovenous malformation in all of its glory on a sagittal CT angiogram reconstruction. Arterial supply, venous drainage into the cortical veins and superior sagittal sinus, and finally the nidus, the central tangle of abnormal blood vessels where arteries and veins connect directly, bypassing the normal capillary network. Arteriovenous malformations are direct connections between the high-pressure arterial system and the low-pressure venous system. When an artery is directly connected to a vein without the intervening capillary network to slow down the flow, the vein, which isn't designed to handle such high pressure, can rupture and bleed. The risk of bleeding depends on the size of the AVM and the type of venous drainage. For example, larger AVMs like this one, or those with deep venous drainage, have a higher risk of bleeding as compared to the smaller superficial ones. Moving right along. Now let's talk about vasculopathy. The most common vasculopathy in adults is cerebral amyloid angiopathy, or CAA for short. In older patients, especially those with dementia, the same amyloid that damages neurons can also affect cerebral blood vessels. It makes them brittle and more prone to bleeding. And neuroimaging often shows evidence of this chronic bleeding. This is the susceptibility-weighted imaging, SWI sequence of the MRI. You've heard of DWI, this is not that. This is SWI. DWI detected cytotoxic cerebral edema, helping you diagnose ischemic stroke. But SWI is exquisitely sensitive to detecting byproducts of hemorrhage, like deoxyhemoglobin, ferritin, and hemosiderin. Blood products show up as hypointensities. There's no need for me to even label the abnormalities. You can spot them from a mile away. That's SWI. Love that sequence. In these images, there are numerous small, round, and predominantly cortical hypointensities that represent microhemorrhages. Now, take a look at this example from another patient. Here, the dark signal isn't inside the brain, it's outside. Look at that inky black signal in the sulci of the patient's left hemisphere. That's hemosiderin sitting in the subarachnoid space. This finding is called superficial siderosis. In the right clinical scenario, elderly person with dementia, these findings point to recurrent bleeding, likely because of cerebral amyloid angiopathy. And the pathogenesis? You already know the pathogenesis. Amyloid deposits in the leptomeningeal and cortical arterioles. Here's a cross-section of a leptomeningeal vessel stained with Congo red for amyloid. Next, small vessel disease. The very same small vessel disease that occurs in patients with vascular risk factors, especially with hypertension, and that can cause subcortical ischemic strokes, can also cause hemorrhage. Neuroimaging features are as you would expect. The hematoma is subcortical, where small vessels are typically found. Here's a non-contrast head CT showing an acute hemorrhage in the left putamen. Next to the CT is the patient's MRI, with a fluid-attenuated inversion recovery or FLAIR sequence. This sequence highlights chronic injury. You can see paraventricular hyperintensities, which correspond to chronic ischemia caused by small vessel disease. There are also multiple hypointensities that represent chronic ischemic small vessel infarcts. What about the pathogenesis? You might remember that lipohyalinosis is the hallmark of ischemia in small vessel disease. But in this case, damage to the small vessels weakens their walls and leads to aneurysmal dilatation. Here's a pathological slide of a cross-section through a small vessel. The trichrome stain highlights collagen in blue and fibrin in red. On the left, you can see the normal portion of the vessel and its lumen. But on the right, there's a massive aneurysmal dilatation. This is known as a Charcot-Bouchard aneurysm. Now, it's a terrible term that I would really like you to forget. In clinical practice, the word aneurysm typically refers to saccular aneurysms in the circle of Willis. You know, the ones that cause subarachnoid hemorrhage. And lastly, let's talk about hemorrhagic malignancy. This can happen in patients who already have cancer. Now, which 5 cancers are most likely to cause brain bleeds when they metastasize? Melanoma, choriocarcinoma. It's highly vascular, kind of like having a placenta growing in the brain. Renal cell carcinoma, non-small cell lung cancer, and papillary thyroid cancer, which is quite rare. If a patient does not have a known cancer, watch out for the classic B symptoms: unexplained weight loss, fevers, night sweats. Can neuroimaging help us with the diagnosis? Here are two non-contrast head CTs from patients presenting with intracerebral hemorrhage. On the left, we have a left occipital hemorrhagic metastasis in a patient with melanoma. On the right is a patient with right frontal high-grade glioma, a primary CNS tumor. But you wouldn't be able to diagnose that from the CT alone. Performing an MRI with contrast provides that vital clue to malignancy. Both of these lesions enhance with contrast. There's a breakdown of the blood-brain barrier that the contrast is helping us to highlight. So when it comes to hemorrhages, gadolinium is an important diagnostic tool. Following our examples, malignancy may be primary, like the glioma, or metastatic, like the melanoma. But remember that imaging alone can't tell you the exact type of cancer. For that, you need tissue. A biopsy or resection is needed for a definitive diagnosis. In both of these examples, the hemorrhagic masses were resected, and that's how we knew which is which. Pathological classification is great, but since we usually diagnose hemorrhage by imaging, it's more practical to organize these causes by intracranial location. First, subarachnoid hemorrhage. Aneurysm rupture causes bleeding into the subarachnoid space where blood mixes with CSF. The blood first fills the suprasellar cistern, where the circle of Willis is located. Then it spreads into the sylvian fissure and travels along the brain's sulci, following the pathways where CSF normally flows. Subarachnoid hemorrhage happens outside of the brain. Intraparenchymal hemorrhage happens inside of the brain. Primary intraparenchymal hemorrhage can either be subcortical or deep, within the basal ganglia, or lobar, within the lobe of a brain. Intraparenchymal hemorrhage can also result from hemorrhagic transformation of an ischemic stroke, essentially oozing of blood into a necrotic area of the brain that was damaged by ischemia. Hemorrhagic transformation of ischemic stroke is relatively common and usually asymptomatic. It doesn't typically behave as aggressively as a ruptured blood vessel when it comes to hematoma growth or secondary injury. So for clinical purposes, we often don't worry too much about it and we tend to ignore it. Any hemorrhage can spill over into the ventricles, leading to the so-called intraventricular hemorrhage. But it's also possible for an intraventricular hemorrhage to happen on its own, without any subarachnoid or intraparenchymal component. When that happens, it's more likely to have a macrovascular cause. Why aren't epidural and subdural hemorrhages considered hemorrhagic stroke? Epidural hemorrhage happens between the skull and the dura. Subdural hemorrhage happens between the dura and the arachnoid. The meningeal layers separate the hematomas from the brain tissue, so the risk of direct toxicity to the brain from the blood is much lower. And so is the risk of secondary injury. But don't make the mistake of thinking epidurals and subdurals are any less dangerous. Why did we go down this road? Right, we can organize the hemorrhage pathologies based on imaging. Subcortical, deep hemorrhages are typically caused by small vessel disease, and hypertension is the most important risk factor. That's why these are often referred to as hypertensive hemorrhages. It's kind of a bad name since hypertension is a risk factor and not the cause. Lower hemorrhages tend to have more concerning causes like coagulopathy, arteriovenous malformation, vasculopathy, and malignancy. Now, this dichotomy is convenient for learning. It's tempting to just draw a line between the two hemorrhage locations. But in reality, up to 10% of deep hemorrhages can be caused by one of these more concerning pathologies, like coagulopathy, AVMs, malignancy. So just as with ischemic stroke, a workup is always required to diagnose the most likely hemorrhage mechanism. And before we dive into the results of our patient's workup, now that we have some idea of hemorrhage pathologies, this brings up an important question. Which hemorrhagic stroke mechanism is most dangerous? And this concept is best illustrated with cats. Think of most subcortical hemorrhages as a lynx, They're serious, but not the most dangerous out there. Most deep hemorrhages are caused by small vessel disease, which has an annual rebleeding rate of up to 5%. Now, lobar hemorrhages are more like a cheetah, fast and much more dangerous. As I mentioned, lobar hemorrhages can have different causes, and in some cases, like a large ruptured AVM, the rebleeding rate can be as high as 20%. But there's no denying that aneurysmal subarachnoid hemorrhage is a lion. Up to 30% of ruptured aneurysms rebleed within the first month if they're not treated. That's why it's crucial to rule out a treatable aneurysm in any patient with acute subarachnoid hemorrhage. Alright, so let's get back to our case for the final time. Honestly, I'm impressed you're still with me. Our 74-year-old man with multiple vascular risk factors who developed acute right putamenal hemorrhage and now post-minimal invasive evacuation and improving neurologically. Blood pressure is well controlled, coagulopathy was absent, the CT angiogram showed no evidence of a macrovascular cause, the brain MRI did not show any abnormal enhancement or signs of prior bleeding, although there was some evidence of chronic small vessel disease. What is the most likely mechanism of this hemorrhage? Yes, small vessel disease. Congrats, we've come to the end of this talk. You made it. All that's left is to summarize the management and mechanisms of acute hemorrhagic stroke. A patient presents within 24 hours of their last known well time with acute focal neurological deficits. Activate a stroke code. Keep in mind, acute focal neurological deficits with symptoms of elevated intracranial pressure, like headache, lethargy, confusion, might suggest a hemorrhage. But that's almost a moot point because you'll need imaging to differentiate between ischemia and hemorrhage anyway. So proceed with imaging. Non-contrast head CT first, followed by a CT angiogram with contrast. You should still perform vascular imaging regardless if the stroke is ischemic or hemorrhagic. For hemorrhage, vascular imaging can help you identify active bleeding, like the spot sign. Spot sign can predict hematoma expansion. It also helps you check for a macrovascular cause, like an AVM or an aneurysm. Once a hemorrhage is diagnosed, the next goal in management is to prevent secondary injury. The main threat causing secondary injury is hematoma expansion, especially in the first 3 hours. There are two main strategies to prevent expansion: control the blood pressure and correct coagulopathy. Both of these interventions are medical, not surgical. Blood pressure goal should be rapidly reduced to a target of 130 to 150 millimeters of mercury systolic, and any coagulopathy should be promptly reversed. Unless a patient is experiencing an intracranial pressure crisis, neurosurgery for intraparenchymal hemorrhage is not appropriate in the ultra-early phase, at least based on current evidence. So in most patients, your focus should really be on controlling the blood pressure and correcting coagulopathy, not calling neurosurgery. Oh, and speaking of blood pressure, I bet you're a bit overwhelmed with all the blood pressure goals for stroke management, so let's go over them. For acute ischemic stroke, we aim to keep the blood pressure below 220 over 110 millimeters of mercury. Going above that increases the risk of organ damage, and going below that increases the risk of more ischemic injury. If a patient is getting intravenous fibrinolysis, the target drops to below 180 over 110. Blood pressure higher than that increases the risk of hemorrhagic transformation. Once reperfusion has been achieved, we aim for a lower systolic range of 120 to 160 millimeters of mercury. Allowing the blood pressure to stay higher raises the risk of hemorrhagic transformation, and we gain nothing by pushing higher blood pressure once the vessel is already open. Now, keep in mind that reducing the blood pressure with acute ischemic stroke is not safe, unless there's clinical stability, neuroimaging stability, and clinically significant vessel stenosis is absent. For acute hemorrhagic stroke, we bring the blood pressure down immediately, to a systolic range of 130 to 150 millimeters of mercury. And finally, for long-term stroke prevention, the target is less than 130/80. We aim to achieve this goal by the 1-month follow-up visit in the clinic. Once the blood pressure is controlled and coagulopathy has been reversed, the patient should then be admitted to the ICU, because they're at high risk for deterioration. If signs of elevated intracranial pressure worsen because of hematoma expansion or perihematomal edema, then hematoma evacuation may be considered. The general indications for surgical hematoma evacuation are within a 72-hour window, hematoma size needs to be large enough to justify surgery, usually over 30 cc's, and the patient must have enough neurological function left to salvage, meaning the hemorrhage cannot have caused herniation or destroyed vital parts of the reticular activating system, like the midbrain, potentially leaving the patient in a permanent coma. Hematoma evacuation will not help if the catastrophic damage has already occurred. Also, minimally invasive approaches are safer, but the patient needs to be clinically and radiographically stable before attempting it. Regardless of the choice of intervention, evacuation must be complete if we hope to improve neurological outcome. Once you've addressed secondary injury, the focus shifts to preventing recurrence. This means completing a hemorrhagic stroke workup. There are 6 major mechanisms for hemorrhagic stroke. Decreased clotting potential is one, and there are 5 mechanisms of vessel injury. Rupture of saccular aneurysms, which leads to subarachnoid hemorrhage. Rupture of an arteriovenous malformation. Vasculopathy, such as cerebral amyloid angiopathy. Small vessel disease. And disruption of leptomeningeal arterioles, which form part of the blood-brain barrier. This is usually caused by a neoplasm. So we start with a basic coagulation panel to check for any coagulopathy, and sometimes we send additional tests, like anti-10A, P2Y12, where appropriate. To assess for a macrovascular cause, we use CTA or MRI of the head with contrast. We also perform an MRI of the brain with gadolinium to look for a neoplasm. MRI has special sequences which are particularly useful in identifying chronic microbleeds, which is a sign of vasculopathy. Here's an imaging-based organization of all the pathologies. Subarachnoid hemorrhages occur in the subarachnoid space, with saccular aneurysms being a key cause. Intraparenchymal hemorrhages occur within the brain parenchyma and can be subdivided into subcortical, or deep, and lobar. There's also hemorrhagic transformation of ischemic stroke, which can occur anywhere in the brain. Anywhere there is ischemia, that is. Hemorrhagic transformation is usually easier to diagnose because it presents as small amounts of hemorrhage within the larger necrotic ischemic core. Subcortical hemorrhages are typically caused by small vessel disease, with hypertension being the most important risk factor. Lobar hemorrhages tend to have more dangerous causes like coagulopathy, arteriovenous malformation, vasculopathy, and malignancy. Neuroimaging classification is nice, but a workup is always required to diagnose the most likely hemorrhage mechanism. And that's all for today. As always, thank you for your kind attention, and we'll talk again soon. Bye!